My name is Federica Viggiamo, and today we have the pleasure of interviewing Dr. Nicholas Caputo, an emergency medicine specialist at Lincoln Medical Center and New York Presbyterian Hospital. Can you tell us what your position is about outside the COVID-19 pandemic?
Sure. So I am an emergency medicine physician. My position at New York City Health and Hospitals Lincoln is as the Associate Chief of the Department of Emergency Medicine. Lincoln Medical Center is part of the New York City Public Hospital System, known as New York City Health and Hospitals. We're an 11 hospital system that basically cares for the mission of the system is to care for the poor, uninsured aspects of the population. And then my position within New York City Health and Hospitals is, again, as the Associate Chief of the Department of Emergency Medicine. And so what that entails is a mixture of both clinical responsibilities and administrative responsibilities. So those administrative responsibilities are dealing with everything from emergency department throughput, so door-to-doc time, time in treatment, dispositioning, working on different ways to sort of expedite care, improve quality of care. I also work in aspects of quality in terms of quality indicators for CMS, or the Centers for Medicaid and Medicare, looking at things such as our sepsis care, our care for patients that are having myocardial infarctions, our stroke care, our trauma care. Also, what falls under my purview is research. I supervise all of the department's research for the adult side of the emergency department. And then on the clinical side, I work basically as an emergency physician within the department, mostly a nocturnist, meaning I work mostly at nights. And then at New York Presbyterian, Columbia University Medical Center, I'm purely clinical, so I do clinical shifts there. As a side note, I have some other things that I do. I do concierge medicine here in the city, which is basically, I have a private practice with a couple of other physicians where we handle the cares of members who pay for access. And then I also serve in the United States Army as a reservist, again, in my aspect as an emergency physician.
Thank you.
Good morning, I'm Arianna Tarascio. I'd like to ask you, how has the COVID-19 pandemic changed your daily work in the ward and more in general, hospital organization?
Sure. So really good question. Thank you. The pandemic presented a sort of, mass casualty incident type scenario that was protracted in nature. So, we knew a surge was coming. However, we didn't know the extent of neither the surge or the period of time that it would last. So for us, we found ourselves having to adapt very quickly, not only as a department, but as a hospital and a system as well. Prior to COVID, we, in the emergency department, Lincoln is one of the busiest emergency departments in the United States. We see about 170 to 180,000 patients per year. That's anywhere between 400 and 500 patients a day. And being a public hospital, we're pretty under-resourced and understaffed. So at baseline, we're already struggling to sort of like keep up with the patient flow. When COVID hit, the numbers surged a little bit in terms of our daily volume, but what really impacted us was the criticality of the patients. And this compounded with our inexperience with the pathophysiology of the virus, and our lack of knowledge of how to kind of manage the virus and patients with the virus, led to really a unique situation where we had to really think on our toes and adjust in real time in terms of, how do you flex up a hospital that has 40 ICU beds to one that needed 200 ICU beds? How do you increase space and staffing when you have a finite amount of both, basically? So what had happened was, during the pandemic, administratively, we started meeting multiple times a day to sort of touch base and adjust the plan as, data was coming in real time. So we were getting patient numbers coming in real time. Who needed ventilators? Who didn't? How many ICU beds were available? What units could be converted to an ICU? And we were kind of making adjustments in real time. When data started coming out of Italy, that sort of gave us a heads up that intubating patients wasn't the best way to go, and that it was causing higher mortality than expected. We started to adjust bedside care accordingly with things like proning and supplemental oxygen in conjunction with proning. So it really presented a challenge to us, both logistically and clinically, that we had to sort of manage in real time. I think there were definitely areas where we excelled and areas where we really were, behind the ball in terms of our ability to sort of manage the situation.
Thank you.
You're welcome.
Good morning, I'm Giuseppe Rocca. We have heard that it has been very challenging accepting COVID-19 patients at the intensive care unit. Have you applied any specific criteria to decide on patient admissions?
So yes, we did, and really the admission criteria for us was one of two things: either you were intubated and needed to go to the ICU, or you weren't intubated but you had certain hemodynamic and biochemical parameters that were applied because they indicated that you needed a higher level of care in terms of observation. So for intubation, we came up with some triggers to intubate. Pretty early on within the pandemic surge. Those triggers were, the tricky part about COVID was this thing known as silent hypoxemia. So it was patients who were presenting who didn't look like they were in respiratory distress, yet their O2 sats were in the 70s, 60s, or 50s, and this led to sort of like a trigger pull or reflex intubation by the clinicians. So people were getting intubated who probably didn't need to be intubated. And so we quickly came up with triggers for intubation, which were, hypoxemia in conjunction with altered mental status, or with air hunger, or with, dyspnea, things of this nature, in which things like, patients' inability to tolerate proning didn't work, or a escalation of supplemental oxygenation didn't work. So if you got intubated, if you met those triggers for intubation, you got intubated, then you went to the ICU. The other aspects were, patients with unresolving renal injury. So if you were in acute kidney injury and it wasn't resolving, if you had in combination with a lactic acidosis or high LDH or other signs of a pretty severe COVID infection, which there are several lab values that sort of correlate with patients who do more poorly in these situations. Again, D-dimers, LDH, lactic acidosis, renal injury. Those were sort of our telltales that said, all right, this patient's going to need more aggressive care and more aggressive observation in order to get them through this. Though they didn't necessarily need to be intubated right away. They needed to really be bird dogged or have eyes on constantly in order to determine which way they would go in terms of their outcomes.
Thank you.
No worries.
Good morning, I'm Giulia Scodellà. It must have been very challenging for you facing the COVID-19 pandemic. Have you observed any implication of this pandemic in the mental health of medical workers?
So, yeah, it's a difficult question because we've seen a lot of our healthcare workers really suffer depression. One of my good friends actually took her own life from this experience. There was one of my colleagues at Columbia. Actually, she was the medical director at the Allen Pavilion. And so, yeah, the impact on not just medical providers, but on the staff in general in terms of the mental health has been very burdensome, I think. Fortunately, the administrations here at Health and Hospitals and at New York Presbyterian have set up sort of supportive services for those healthcare workers who are sort of struggling to deal with sort of a post-traumatic stress syndrome like illness, where you're kind of exposed to a high volume of mortality in a short period of time. I've said in other interviews, I've pronounced more patients dead and have informed more families of loved ones that have died in the last 3 months, or in those that 12-week period where we were surging and we had COVID going on, than I did in my last 10 years of practice. People tend to think that emergency physicians deal with only critically ill and dying patients all the time, but that's not actually the scope of our practice. You can go months at a time without having a patient die under your care. So to have almost every shift multiple patients die, and then having to inform family and not being able to do it in the traditional way of face to face in a grieving room, and being able to offer a hand or a hug or anything like that was difficult, because you were doing it out in the parking lot because the family wasn't allowed inside the hospital. You're doing it through FaceTime or over the phone. So it presented new challenges to us that we kind of had to try to adjust to. And I think it was difficult for most people. Yeah.
Okay, thank you.
You're welcome.
Good morning.
Good morning.
I'm Carmelo Roggio. In these days in US cities, we have seen dramatic scenes of demonstrations turning at times into violence. Do you think this could be somehow linked to the distress caused by the COVID-19 pandemic?
Yeah, so great question. I do think there is probably a link in terms of just the amount of tension it brings. You have demonstrations, initially about the lockdown and how it was impacting people's lives, personally and financially, and really small business owners. My wife and I, we own a wine bar in the city, and our wine bar got shut down, right? And so really demonstrations started as a pushback to what people thought was sort of overkill in terms of trying to flatten the curve. But you added into that aspect, issues behind police brutality and racism and things that are sort of outside of the realm of the pandemic, but it sort of, elevated that tension in the streets. And there were riots. I worked several shifts in the last few weeks where I took care of both injured police officers and injured rioters and injured peaceful protesters. And so, all of them had the same concerns, whether or not they were exposed to COVID, so they're all out there for reasons other than COVID. But when they came to the ER, and after they were cared for, the next question was, well, do you think I got COVID and now am I going to get sick? And so I do think there was a link there, because you're already protesting, one, because of the lockdown, right? And then these police brutality protests start, and that compounds. And then, you put into that, not supposed to really congregate in close proximity with a bunch of other people, and there are tens of thousands of people out in the street. So I do think that sort of escalated things to a point, not really of no return, but to a point we haven't been to in a very long time as a country.
Thank you very much.
You're welcome.
The last question. What do you feel to tell medical students at the beginning of their path to become physicians?
Yeah, so this is a question that we obviously get a lot every July. July is when our graduating medical students start their residencies, and when the graduating college students start their medical school pathways. And so generally what I tell the residents is, follow through is probably the best thing you can do for your career. So when you're discussing things with a patient or you're discussing things with a colleague, following through on what you sort of are advising them, or collaborations that you're kind of talking about. So things like this, like, Professor Travato reached out to me, and we started a discussion and talking about possible collaborations on research and writing papers. And then he asked me to do this interview, and it's actually this moment following through and saying, like, yeah, no problem, I'll do it, as opposed to kind of just keeping people sort of on a hook. And that's a big deal, because I've been out for 10 years, and I've worked with many med students and many residents who always come to me and say, hey, I want to do research with you, I want to publish. Well, that's great, that's fine, but rarely do any of them follow through and actually produce a paper, produce a final study. Now I do it, right? But the purpose of collaboration and mentorship is to get the person that is has less experience in it, that experience, to elevate their not just their career, but their understanding of the processes of doing research, and how that applies to physician care and patient care and bedside care, and how that translates into progression of the specialty in general. So follow through is a big one. I think doing research, number two, is huge, because it helps you to better understand the patient population that you care for. So I've been doing research in the South Bronx for well over 10 years. I started as an intern my first year here, because I wanted to better understand the population that we treated. And you find things within that experience that are counterintuitive to what you're actually being taught, right? So, for example, one of the things I was taught here is that all of our trauma patients who are really sick come in, they're hypotensive, they're tachycardic. And so I started to look at that. I started to see, all right, what do our trauma patients actually look like? And we found that they were kind of the opposite. They were young, they either had normal blood pressure or were hypertensive, and they were somewhat normal cardiac. So we had patients that were going to the operating room and that were getting massive transfusion protocol that had basically normal vital signs, but they had very severe traumatic injuries. So that was one of the myths that had been propagated over time, just through conventional wisdom. So I think by doing research on your own patient population, it helps you to better understand, number one, who they are, and better treat who they are, and the pathologies that they suffer from. Because most of our knowledge in medicine is conventional, and conventional wisdom is sort of just passed on. It's not actually evidence-based. So I do a lot of research in the areas of challenging conventional wisdom within medicine to see, are we actually providing our patients with the most effective care that we can. So I would say, number one is follow through. That's going to help you advance and help your career advance. Number two is doing research. And number three really is understanding that when you start your career, even though you graduated from med school and all this stuff, you have to know one thing, that you really know nothing. That, it kind of is a difficult pill to swallow. But when you graduate med school and you get into residency and your real training, you're really starting from scratch. You kind of have the basic foundational knowledge of the pathophysiology and everything like that, but bedside medicine is very different than your basic sciences. Those basic sciences give you a foundation, but very rarely do the two meet in a way that is textbook. In fact, when you do have a textbook case of anything in the emergency department, like, that is call for celebration. People run around like, hey, I got a textbook case of appendicitis, because rarely do you find a textbook case of appendicitis. Rarely do you find a textbook case of stroke. It's really keeping an open mind and understanding that you don't know everything when you come out of med school. And I think in being open-minded that way, it's going to allow you to learn from your experiences. You know, one of the things I was taught is that good judgment comes from experience and experience comes from poor judgment, right? So the caveat of that is learn from other people's experiences. So, you know, talk to your seniors, talk to your attendings or your consultants, and get their experiences, because they've definitely seen things before that you're going to be able to learn from, right? Don't go into it thinking that, all right, I've graduated, I know enough, I can sort of, you know, start doing things on my own. That's how patients end up having poor outcomes. So I would say those things are usually the advice I give to med students and new interns, residents coming in to the new year.
Okay, thank you very much.
You're welcome.
Okay, I think that we have finished. I wanted to thank you so much and for sharing your precious experience with us, and thank you for your time, obviously. And I wanted also to thank Giovanni Valenti, who helped us to keep in touch with you, and thank you.
No problem, guys. Thanks so much, and good luck with everything.
Thank you for your time.
You're welcome.